what healthcare boards should demand from CTOs in 2026.
Hello and welcome. In this video, we are digging into what CEOs and boards should expect from a healthcare CTO in 2026. This is not a narrow technology topic. It is really a leadership question about how healthcare organizations decide, modernize, govern, and execute when the stakes are high and the margin for architectural drift is low. If you are a CEO, board member, CIO, CTO, chief digital officer, clinical executive, or transformation leader, this subject matters because it sits right at the point where strategy turns into real operating capability. Too many organizations talk about modernization in abstract terms, but this topic forces a more practical conversation. It asks what should actually change, what should stop, what leaders should expect from their teams, and how they can tell whether the enterprise is building something durable or just funding a more expensive version of the status quo.
By the end of this script, I want to make the issue clearer, more concrete, and more actionable. The reason this matters right now is simple. As of now, healthcare leaders are making technology decisions in an environment shaped by stronger interoperability requirements, tighter cyber expectations, rising AI ambition, and persistent pressure to simplify operations while proving financial value. That means the old pattern of treating architecture, governance, vendor selection, and workflow adoption as separate conversations no longer holds up. A decision in one area now reshapes the economics and risk profile of the others. In the healthcare sector, that interdependence is even sharper because every technology move touches regulation, privacy, clinical operations, revenue cycle realities, and workforce strain. So when we talk about what CEOs and boards should expect from a healthcare CTO in 2026, we are really talking about the organization's ability to move with discipline. The winners over the next several years are not likely to be the ones that buy the most tools or announce the biggest AI initiative. They will be the ones that connect strategy, platform design, governance, and operational adoption in a way that compounds value instead of compounding friction. At the center of this topic is a very practical idea. In 2026, CEOs and boards should expect a healthcare CTO to translate technology into business capability. That means creating faster clinical and operational workflows, safer AI adoption, stronger resilience, and clearer capital allocation logic. Technical fluency matters, but executive synthesis matters more. That sentence may sound straightforward, but it carries major implications. It means leaders can no longer afford to think of technology as a collection of projects owned by different departments with different budgets and different definitions of success. In modern healthcare, the real unit of value is the system, not the tool. A single workflow may depend on clinical data, identity controls, cloud infrastructure, policy decisions, analytics logic, vendor integrations, and human review patterns. If those pieces do not work together, the organization gets motion without real progress. That is why this topic deserves a full strategic treatment. The surface question may appear to be about boards, should, expect, healthcare, but underneath it is a deeper question about enterprise design and the conditions required for scale. To understand why this issue keeps resurfacing, we have to look at the industry backdrop. Healthcare has spent years layering new capabilities on top of old environments. EHR ecosystems expanded, data estates multiplied, digital front doors appeared, cloud migrations accelerated, and now AI is arriving across the stack. But most organizations did not get the luxury of starting from a clean slate. They inherited line of business solutions, local optimizations, specialist teams, and a patchwork of governance habits built for an earlier era. That history matters because it explains why even intelligent organizations can struggle to make coherent progress. They are not simply choosing among modern options. They are trying to modernize while carrying old constraints, old incentives, and old ownership boundaries. The topic we are discussing is best understood as a response to that accumulated complexity. Now, let's talk about what leaders often miss, because that is usually where the most expensive mistakes begin. The wrong expectation is that the CTO should simply keep systems stable while everyone else decides strategy. Stability is table stakes. The harder job is choosing where standardization creates leverage, where differentiation matters, and how technology risk should shape growth decisions, partnerships, and acquisitions. The trap is not a lack of intelligence. It is a mismatch between how organizations frame the problem and how the work actually behaves once it reaches production. Many healthcare strategies still assume they can solve for speed in one lane, risk in another lane, and adoption in a third lane. In reality, those lanes are fused. A technically elegant idea can still fail if ownership is unclear. A well-governed initiative can still fail if the workflow never changes. A financially justified platform can still fail if every team treats it as optional. Once you see that pattern clearly, it becomes easier to understand why so many programs look promising at kickoff and frustrating a year later. The next question is why old approaches keep surviving even when people know better. Part of the answer is that fragmented decision making produces local wins quickly. A department can buy a point solution, a team can stand up a bespoke data feed, or an innovation group can launch a pilot faster than the enterprise can build shared capability. Those local wins create the appearance of momentum. The bill arrives later, usually in the form of overlapping contracts, duplicated integrations, inconsistent metrics, more manual reconciliation, slower approvals, and a growing sense that no one can quite see the whole picture. In other words, the organization begins to operate as a collection of exceptions. That is why leaders need to examine this topic through a systems lens. Local convenience and enterprise progress are not the same thing, especially in a regulated industry with complex operational interdependencies. So, what does good look like? A high performing CTO should present a technology roadmap in business terms. What platforms will be consolidated, what capabilities will be built once and reused broadly, what AI use cases will be scaled, and what risk controls are non negotiable. They should also expose trade offs honestly. Not every clinical request deserves a custom build, and not every vendor promise should become enterprise architecture. The important point is that good looks integrated before it looks impressive. The best healthcare technology strategies do not start by asking which tool feels most modern. They start by asking what future operating model the organization is trying to create, what capabilities should be reusable across domains, and what forms of variation are genuinely necessary. That mindset changes everything. It changes which platforms get funded, which interfaces are standardized, which teams need to be brought together, and which measures of success actually matter. It also makes it easier to distinguish innovation from noise. Once the enterprise knows what good looks like, it becomes much harder for attractive but misaligned investments to slip through just because they seem urgent. From an architecture perspective, this topic belongs squarely in the world of enterprise design rather than isolated solutioning. In healthcare, architecture is not just about technical elegance, it is about survivability, interoperability, auditability, and the ability to support many use cases without rebuilding the foundation each time. A strong architectural stance means deciding where standardization creates leverage, where abstraction is worth the effort, and where local autonomy would simply multiply hidden cost. It also means understanding that every custom interface, every one off workflow, and every special deployment path becomes part of the organization's long term operating burden. When leaders overlook that, the architecture quietly turns into a tax on future change. When they handle it well, architecture becomes a growth enabler because the next capability launches faster than the last one. Now bring data into the picture. No matter how the topic is phrased, healthcare modernization eventually runs into data reality. Shared context, trustworthy definitions, timely access, lineage, stewardship, and reuse all become decisive. That is true whether the goal is executive decision making, automation, analytics, clinical workflow support, research enablement, or revenue optimization. If the data layer is fragmented, misunderstood, or constantly recreated, then every strategic objective above it slows down. This is why mature organizations increasingly talk about data products, governed access layers, and common control planes instead of just warehouses or feeds. The real objective is not to centralize for its own sake. It is to make trusted context available to the right teams at the right time without forcing them to restart the same integration and definition debates over and over again. AI adds another layer of urgency. For many healthcare leaders, AI appears to be the headline topic, but in practice, it exposes whether the broader foundation is strong enough to support intelligent systems at scale. Models, copilots, and agents all depend on access patterns, policy controls, grounded context, evaluation methods, monitoring, and workflow ownership. If those elements are weak, AI tends to magnify organizational confusion rather than remove it. That is especially important in an executive leadership discussion like this one, because leaders can be tempted to evaluate AI only through the lens of novelty or excitement. A more disciplined view asks a different question. Does the enterprise have the conditions required to turn AI from a pilot into a governed production capability? If not, the answer is not simply to slow down. It is to strengthen the underlying operating system of the organization. Cloud and platform choices matter here as well, but not in the superficial sense of choosing a fashionable vendor. The real cloud question is whether the organization is building a platform environment that reduces repeated work, improves control, and supports a faster path from idea to production. In other words, are teams inheriting reusable services, standard security patterns, identity integration, observability, and deployment paths? Or are they still negotiating those basics every time a new initiative appears? That distinction is what separates genuine platform progress from cloud hosted fragmentation. In healthcare, it also shapes disaster recovery, resilience, cross domain sharing, and the enterprise's ability to respond when regulatory expectations or market conditions change. A well designed platform does not eliminate complexity, but it does keep complexity from leaking into every single program. At this point, we have to talk about operating model because this is where many strategies either become real or quietly fall apart. An operating model defines how decisions get made, how work is prioritized, who owns what gets standardized, how exceptions are handled, and how progress is measured. Without that layer, even strong architecture can remain theoretical. In healthcare, operating model design has to account for clinical input, business ownership, technical delivery, security review, compliance obligations, and the practical reality that change fatigue is real. The organizations that make this work do not rely on heroic coordination forever. They create repeatable patterns for intake, design, governance, release, and measurement. That is why topics like this one should never be treated as purely technical. The operating model is what decides whether the strategy can survive contact with normal organizational life. Governance and risk management deserve their own spotlight. Current healthcare guidance makes it clear that leaders are expected to be more deliberate about cybersecurity, transparency, interoperability, and the use of AI in real production environments. ONC's HTI 1 final rule raised the bar on algorithm transparency in certified health IT. CMS has continued to push API-based interoperability and prior authorization modernization. HAs has proposed stronger HIPAA security rule requirements in response to the sector's cyber threat environment. This continues to provide a practical AI risk management frame, and FDA guidance remains highly relevant where software crosses into regulated medical device territory. The lesson is not that every organization must move at the same pace. The lesson is that governance is becoming more operational, more continuous, and more entangled with architecture choices. Good governance now needs to accelerate responsible delivery, not just review it. Now let's bring the economics into focus. The financial case around what CEOs and boards should expect from a healthcare CTO in 2026 is really just about direct savings. It is about reducing duplicated effort, lowering the cost of future change, improving speed to value, protecting resilience, and making talent more productive. Some benefits show up as hard dollar reductions, such as contract rationalization, infrastructure simplification, or lower manual rework. Others appear as avoided cost, faster launch cycles, better capacity use, improved denials performance, stronger cyber posture, or the ability to scale a successful use case across multiple service lines instead of rebuilding it each time. Executives sometimes miss this because they evaluate technology programs with a narrow project lens. But platform and operating model decisions produce portfolio level consequences. They alter the economic shape of the enterprise. That is exactly why boards should care about them. Of course, none of this matters if people cannot use the result naturally. Workflow and adoption are where technology strategy becomes visible to clinicians, operators, analysts, researchers, and administrators. If the solution adds clicks, hides context, creates duplicate review steps, or asks teams to leave their normal process to chase value somewhere else, adoption will stall. That is not a user problem. It is a design problem. In a strong environment, the architecture and the workflow inform one another. Data appears where decisions happen. AI recommendations are grounded and reviewable. Escalation paths are clear, accountability is visible, and training reinforces a workflow that already makes sense instead of compensating for one that does not. When leaders understand this, they stop treating adoption as a communications exercise and start treating it as proof that the underlying design is sound. Another hard but necessary conversation involves build, buy, and partner choices. No healthcare organization can or should build everything. At the same time, buying quickly without a platform view can mortgage flexibility for years. The right approach is usually to buy common capabilities where the market is mature and interoperability is strong, build the parts of the workflow or orchestration layer that truly create strategic distinction, and partner where outside expertise meaningfully accelerates value without trapping the enterprise in dependence. That framework is especially important for a topic like this because leaders often confuse speed of acquisition with speed of outcomes. They are not the same. A product can be purchased in a quarter and still delay value for years if integration, governance, or workflow fit are weak. Strategic discipline means asking what future change will cost before approving today's solution. If I were translating this into a practical 12-month roadmap, I would start with 3 moves. First, build a brutally honest baseline of the current environment, including ownership gaps, duplicated platforms, major workflow pain points, security dependencies, and where important data is still being reconstructed too many times. Second, define a smaller number of shared platform priorities that can serve multiple business outcomes rather than funding isolated modernization in parallel. Third, pick early implementation targets that matter enough to prove value but contained enough to govern well. Those targets should have named business owners, measurable workflow outcomes, clear technical patterns, and an explicit plan for reuse. The goal over 12 months is not to finish transformation, it is to establish architectural direction, credibility, and repeatability so the next wave of work gets easier rather than harder. Leaders also need a scorecard. They should ask whether delivery is getting faster, whether new use cases are inheriting shared controls by default, whether adoption is occurring inside real workflows, whether duplication is falling, and whether the organization can explain who owns the most important capabilities. They should ask whether security posture is strengthening as scale grows, whether data trust is improving, and whether AI use cases are moving from isolated pilots into governed production patterns. They should also look for early warning signals. Rising exception counts, one-off integrations, unclear data definitions, slow approvals, and persistent manual reconciliation usually indicate that the strategy is still fragmented. Metrics should not just prove activity. They should reveal whether the enterprise is becoming more coherent, more governable, and more capable of turning technology investment into repeatable organizational advantage. Looking forward, the future of what CEOs and boards should expect from a healthcare CTO in 2026 will likely be shaped by convergence rather than a single breakthrough. Interoperability pressure will continue, AI governance will mature, cyber expectations will tighten, platform engineering will become more important, and health systems will be judged less by how many tools they have and more by how effectively they combine data, cloud, workflow, and operating model discipline into practical capability. That future favors organizations that simplify aggressively, make decisions once where possible, and invest in reusable infrastructure for trust, policy, and delivery. It does not favor enterprises that treat each new technology wave as permission to add another layer of disconnected software. The strategic question is not whether change is coming. It is whether leaders are building an environment in which change can be absorbed, governed, and turned into performance. So let's close by returning to the executive level. Boards should expect quarterly evidence on adoption, value realization, cyber posture, delivery speed, and simplification. They should also expect the CTO to partner tightly with the CIO, CDO, CMIO, CFO, and compliance leaders rather than operate as a distant technical authority. And if you keep only a few points from this conversation, keep these. Expect business outcomes, not just technical updates. Expect explicit trade-offs on cost, speed, risk, and differentiation. Expect the CTO to lead simplification as aggressively as innovation. What CEOs and boards should expect from a healthcare CTO in 2026 is ultimately a test of whether the organization is willing to match technological ambition with architectural discipline and operating clarity. That is where durable advantage comes from in healthcare. Not from noise, not from novelty, and not from isolated wins that never compound. It comes from designing the enterprise so that good decisions reinforce one another over time. Thank you for watching.